So Pompilio Pizot, many thanks for having accepted to answer to some questions for our diploma. You are one of the German leader in the management of peritoneal surface malignancy, and we would like to ask you some question on the perioperative management into the overall multidisciplinary approach to treat peritoneal surface malignancy. So, do you think that all patients, whatever the etiology of peritoneal malignancy is, should be treated by a neoadjuvant treatment? Systemic.
Systemic, yeah. Well, I think this is a quite difficult question. In those tumor entities where we know that chemosensitivity is available, like for colorectal cancer, I think this makes sense also for gastric cancer, as for advanced tumors, the neoadjuvant treatment with systemic chemotherapy is already established. For other entities, this part of gastrointestinal tumors could be also an option, like for instance for ovarian cancer. But the standards are different in different countries. For instance, in my country, neoadjuvant treatment is not accepted as a standard treatment. But in other countries, like probably France or Belgium or England, this will be the case, in particular for those cases which cannot be resected completely. So
have you still, for colorectal carcinomatosis, some patients that you will treat by upfront complete cytoreductive surgery and IPEC, or should you try as much as possible to deliver neoadjuvant treatment?
Well, in fact, we do a study, a phase 2 trial with 60 patients on this issue where we include all patients. So all patients that will be suitable for surgery, providing they have an amount of tumor which is lower than PCI, peritoneal cancer index, than 20. But if you do an analogy to liver metastasis, and you would take somebody who had metachronous peritoneal carcinomatosis, a patient who had had his adjuvant chemotherapy years before, and he has a limited disease, maybe one quadrant. This is somebody I think who would rather benefit from straight cytoreductive surgery and HIPEC. And I know from my own experience that the tumor board in such situation will decide not to go for any adjuvant treatment. However, if you have somebody with like for liver metastasis with a potential irresectable disease or with a tumor in the mesentery, I think that's a situation where you, at any rate, first should perform a neoadjuvant treatment.
Okay. So all the decisions for perioperative management are taken into multidisciplinary staff, I imagine, in Germany. So for your point of view, who should decide the tip, the time, and the modalities of systemic perioperative chemotherapy? Surgeon, oncologist surgeon, or oncologist?
Yeah, well, as you said, it's a tumor board decision. So this patient will be evaluated from the very beginning. In Germany, there are more than 250 certified colorectal cancer centers. So all these patients have to be discussed in those tumor boards. And the decision will be taken particularly by the surgeon, by the gastroenterologist, and of course medical oncologist regarding the neoadjuvant treatment, yes or no. And also the duration. The duration could be up to 3 months, an analogy to liver metastasis, but it could be even shorter for somebody, for instance, who had surgery somewhere else 6 weeks before, and we need to overreach the time to surgery for 6 to 8 weeks, and then we'll give them less than 3 months chemotherapy altogether. So after that, the patient will be reevaluated in a tumor board to take the decision if a laparoscopy, for instance, is necessary or not, or otherwise go directly for surgery. Because it's an induction chemo or a neoadjuvant chemo, we will choose the most effective treatment. So this will be according to the last data we have from Germany, at least presented at ESMO 2 weeks ago. we will go for a combination for at least for the RAS wild type, including cetuximab, probably as a backbone, FOLFIRI, otherwise FOLFIRI, FOLFOX, and Avastin, or other types of antibodies.
And for patients who has KRAS mutation, do you go to the use of anti-angiogenic agent, or you prefer not to perform it in neoadjuvant setting?
Well, we have some data indicating that there might be some more intestinal complications. However, I don't have bad experiences on liver surgery and that issue. So if it's for limited time, and if you have a break of at least 6, rather 8 weeks antibodies, in the meanwhile you can give them chemotherapy, then it should be safe.
Okay. So if you have a different study that your phase 2 trial to conduct today in colorectal carcinomatosis to evaluate the perioperative treatment, which study would you conduct?
Well, phase study is the first step in conducting such a trial. So I think you would need a phase 3 trial, and you will basically have to randomize particularly the neoadjuvant treatment, because the adjuvant treatment will be not given to more than 30%, I would guess, of all patients, because the surgery is having still a complication rate, and they will need a lot of time to be able to get the chemo. And we know for colorectal disease, every week is where you have to still to wait to give them chemo will be bad for the prognosis. Therefore, giving them as much as possible, up to 3 months preoperatively, would be probably something that can be randomized. And due to the high incidence of these patients, should be also a reasonable number to include for the study.
So you would randomize the type of neoadjuvant systemic chemotherapy, or neoadjuvant versus no neoadjuvant systemic?
I would randomize neoadjuvant versus no neoadjuvant, because I think they should get the most intensive chemotherapy available, because you want an induction, it's not a pure palliation. You need a maximum of response.
And in your unit, it was possible for you to organize, to schedule this kind of procedure during the 2 or 3 weeks, or it will cause you some problem?
You mean if somebody comes, how long would it take to get? Well, at my unit, it's possible 2 to 3 weeks, but it's not possible if somebody is calling me from the OR for somewhere else and want to transfer the patient. That's of course too spontaneous. But otherwise, it would be possible. If you have a limited number of centers, then of course neoadjuvant treatment would have the advantage that it can be differently be planned, and also include laparoscopy preoperatively.
Okay, many thanks, Pompilio.
Welcome.